Hello, and welcome to the Symplr Education Series webcast. Today's webcast is titled Credentialing, Past, Present, and Future with Kathy Matzka and Ann Hawkins. At the end of the session, we will have time for a formal Q&A, but feel free to ask any questions as they come to mind via the chat box located on the right side of your screen. You will also be able to download the archive of today's webcast and its slides at symplr.com soon, and will receive download information in an email. This program is currently with NAMS for certification, and as soon as we receive that, if it is approved, we will be sending those out via a separate second email. This webinar is sponsored by Symplr, Compliance and Credentialing for Healthcare, which also contains the Cactus Provider Management Platform. Next slide. Next slide. I would like to make some introductions as well as we are so pleased to have Kathy Matzka join us again this month. Kathy has over 30 years of experience within credentialing, privileging, and medical staff services. She holds certification by the National Association of Medical Staff Services in both medical staff management and provider credentialing. Also, our second speaker today is Ms. Ann Hawkins. She is the product manager from Symplr, and she is very much our go-to person within the credentialing realm on the Cactus Provider Management Platform. Without further ado, I would love to turn it over to these two ladies.
Okay, thank you very much. All right, so first of all, the things that we're going to cover is we're going to talk about the CMS requirements for credentialing and privileging. We're going to talk about how the role of the medical services professional has evolved over the years, and from basically a secretarial role to the director type position that we have now. We're going to talk a little bit about primary source verification and documenting clinical privileges and how those processes have changed over the years. We're going to talk about the requirements for communicating privileges, actions to the various stakeholders, and then we're going to talk about some ways of overcoming barriers to effective and efficient utilization of software. When I first started thinking about putting this program together, I found that as a consultant, when I go out to various facilities, that many people do not fully utilize their credentialing software for a variety of reasons. So we're going to talk a little bit. I thought let's tie in to how we do it now, how we used to do it, and the way that we can use our credentialing software to make things easier on us, the way it's designed to do. So first off, why do we do credentialing? Of course, patient protection is the #1 reason. We want to make sure that those people who are providing care to our patients really are who they say they are, that they really did get the training that they've said that they've received, and also that they're currently competent to do the things that they want to do. And we do that because we want to protect patients. And patients, of course, we're patients at our own facility. So those protections extend through the community, they extend to us and to our family. So we want to make sure that the people who are providing those services are really who they say they are and that they're competent and qualified. We also have risk management issues such as negligent credentialing. If a provider injures a patient through an act of negligence and it's determined that the hospital did not appropriately credential and grant privileges to those practitioners, there can be a charge of negligent credentialing against the facility. We've seen more and more of these cases that have grown over the years. Most states now do recognize a tort of negligent credentialing, or they may recognize some other tort like corporate compliance or the governing body's authority as that they are the responsible parties for credentialing and privileging. And as we're hiring more and more practitioners nowadays, of course, there's negligent hiring that also runs with that as well. Also, our accreditation and regulatory requirements, state regulations, and the CMS regulations, and the Joint Commission and HFAP and all the other accreditors do require that we credential. So we have to do that in order to get ours and maintain our state license to be able to treat Medicare, Medicaid patients, and also to be able to pass those accreditation surveys. So let's talk first about the CMS regulations. The CMS regulations have conditions of participation, and they apply to not just hospitals, but ambulatory health facilities, to managed care organizations that want to provide plans, Medicare Advantage plans. They apply to durable medical equipment suppliers and home health agencies. Anyone who wants to provide a service to a Medicare patient has to meet these minimum conditions of participation in order to be able to get paid for those services that they provide. So this is spelled out in the Social Security Act, and that's under the Secretary of the Health and Human Services. And they, when they first looked at this, they decided that there are some minimum requirements that need to be there in order to protect the health and safety of any of those individuals who are being provided that care. A little bit of history. Hospitals weren't always doing a very good job of providing quality care. Back in 1916, the American College of Surgeons did a survey, and that survey was over 2,700 hospitals in both the United States and Canada, and the purpose was to be able to examine the quality of service in those institutions and see just how they were doing with providing good quality services. But unfortunately, that survey and its findings were never published. As a matter of fact, the survey committee ordered that those reports were destroyed when they were evaluating the results, and they found that only 89 of about 700 hospitals that were included in the survey that had more than 100 beds, only 89 of those 700 hospitals could meet any kind of reasonable healthcare standards. So the American College of Surgeons adopted what they called the minimum standards for hospitals. And these were voluntary. They weren't required, but they were asking all hospitals to voluntarily commit to these. Actually, the Joint Commission surveys kind of grew, the Joint Commission standards kind of grew out of these minimum standards. In 1946, Congress passed the Hill-Burton Act, and that resulted in a widespread application of healthcare standards because in order to receive funding through the Hill-Burton Act, states had to start licensing all hospital facilities. So before this time, there was no consistency in which hospitals were licensing facilities. So or which states were licensing facilities. So in order for the states to get that funding, they had to license their hospitals. And in order to do that, they had to also make sure that they adhere to these specific quality requirements. So in 1965, we're fast forwarding another 20 years, and then we have Medicare and Medicaid. So when this is established, Congress established these minimum standards that needed to be met by each facility, and that's when we started having states coming in surveying hospitals and making sure that they complied with Medicare and Medicaid, and then we started, also having the Joint Commission got deeming authority to be able to survey on behalf of the state organizations, and everything kind of grew with our accreditors out of that. So a little bit of history too. Determination that a particular healthcare organization is compliant is done either by doing state surveys, meaning that the state will have to come out and survey the facility and make sure that they are complying with those minimum CMS regulations, or an accrediting body that's approved by CMS can come out and do that for a hospital. And right now we have for the Joint Commission, HFAP, DNV, and the Center for Improvement in Healthcare Quality. So those are the accrediting bodies that if you are accredited by one of those, then you don't have to go through the state surveys. Now, that doesn't mean that the state is not going to survey you, because they do a percentage of what they call validation surveys, where they're just going out and validating that the accrediting organization that is surveying your facility is doing a good job. So you can still have a validation survey, which usually occurs pretty close to the time that you had your accreditation survey. Or states can still come out and survey when they get complaints from people. So you may have a complaint. I remember working with a hospital that a patient complained about their food because they didn't like the fact that they were on a low salt, low fat diet, and when they came into the hospital, that's what the doctor put them on, and they were unhappy with it, called the health department and complained, and it resulted in a survey of the whole dietary services for the hospital. So, states can still come back and do accreditation surveys and also survey validation surveys and those complaint-related surveys. So the Joint Commission, the CMS standards requires some things to be evaluated, some credentials to be evaluated. They require that you have a current licensure, that there are references that can attest to your competency, that you actually request privileges and those privileges are defined, that you have documentation of that practitioner's experience with the privileges that they want to do, and evidence of training and education related to the privileges that they would like to have. Okay, so evolution of the role of medical service professional. Now that we looked at some of the past history of accreditation in a hospital environment, let's take a look at how the medical service professional's role has changed. When I first started working as a medical services professional, I had a job as a secretary. I was hired as an administrative secretary, and I basically didn't know anything about medical staff services. I was hired and put into the job, and there was a pool of people that applied for it, and I was the one that actually a couple other people were given the job, and they just didn't work out or worked for a couple of days and said, I don't want this job, and ended up quitting it. So I got the job, and I was taken into the office and told to sit, there's your desk, there's your computer. I didn't even know how to turn the computer on. That's how, new computers were at that time. I'd never touched one before. So, we're going back, like I said, about 30 years here. So we had, file cabinets that we kept everything in. We did not have electronic records. It wasn't until I had been working for several, maybe 5 or years or more, that we actually started having credentials files that were electronic. And at that time, we had DOS-based programs. So things have evolved very much during that time. Also, our jobs, what we do, has changed significantly. Although we're still doing a lot of that basic credentialing, making sure that people are competent, pulling in all those references and so forth, the things that we do now are totally evolved. We're doing more management of medical staff services. We are managing the whole medical staff function. We're orienting leaders, orienting medical staff members. We're writing bylaws. We're doing so much more than the secretarial job that this first started out as over 30 years ago. So now we're managing the functions, we're managing the department, and we're doing things in we're doing a lot more work basically than what we used to do. It used to be a lot simpler. The job was, show up for a meeting, take some minutes, and now we're planning the agendas, meeting with the department chairman, going over the agendas and all the information that's going to be provided. And in many cases, we're helping to run the meeting. So we're doing a lot more work than what we used to do many years ago. And so the role of the medical services professional has changed, as well as the technology and the role of the different things that we do as far as credentialing. So let's take a look at primary source verification and how these things have changed over the years. So primary source verification is information that comes directly from the issuing source, and we can get it a number of ways. We can have a written thing that we can where we write to someone and they write back to us. We can take a phone call. If we take a phone call, we usually make sure we document key items like the name of the organization, when we talk to them, who we talk to, what we ask them, and their responses to those questions. And of course, our name would be written on there, who actually did the written verification. Or we can use fax machines. Many people still do use faxes. We can use an approved website. And when we say an approved website, that means that it's one that, for example, state websites that are run by the state licensing board. It wouldn't be a third-party type of a website. It would be something that was an approved website. And you can do it internally. You can do it all yourself. You can have a centralized verification organization where if you have a health system, maybe one hospital in the system is actually doing the verification. Ann, are you still there?
Yes, I'm still here. I'm not sure why the music is playing.
Okay, is that the GoToMeeting that's doing that for us?
Let me find out from Callie. Just one moment.
All right. Well, hey, I hope everybody can still hear me. I'm going to go ahead and just talk over the music and kick up my volume a little bit here. Also, we can delegate credentialing. We can delegate the credentialing to another organization. We can hire someone to do this credentialing for us. So we can use their information, and we can use that information to be able to make our decisions at our facility. Designated equivalent sources are agencies that have information or items that are identical to information that the primary source contains. And so what happens here? Hello?
Yes, so sorry.
Everything okay?
Yes, I had someone having some audio issues. I'm helping them out.
Okay, thank you. Okay, so agencies that may have specific credentialing information that's identical to the information at the primary source would be something such as the AMA profiles. The AMA profiles have information that the medical schools and the ACGME accredited training programs send directly to that AMA profile service. So they are deemed to have be a designated equivalent source to getting that information directly from the medical school or the training program. Also, a primary source might designate another organization to be its agent to provide information about verifying credentials. So, for example, the DEA doesn't verify the DEAs. Instead, they have the NTIS, a National Technical Information Service, that does those verifications. So they are the agent that is doing that. They're designated to do it. Okay, so let's look at each of those elements that we need to verify and kind of talk about how they've changed over the years. And Ann's going to be jumping in back and forth with me here, and I'm going to talk about, you know, what we've done in the past, what we can do, what we do now, and then she's going to talk about how software can make things easier for us and help automate some of these processes. So education and training is relevant to be verified. And we need to verify the education and training that is relevant to the privileges that someone wants to have. So for example, say that you have an advanced practice nurse that you're credentialing, and that advanced practice nurse completed, an LPN degree, and then did an RN, and then went on to do her advanced practice degree. So the LPN and RN is really not relevant. What we really need to verify is that she completed the advanced practice degree. So same thing with a physician. Say that you have a physician who did undergraduate training and got a PhD and worked as a PhD psychologist for a while, and then went on and got his medical school diploma and decided to then be a medical doctor and did training in medicine. So we then we don't really have to verify that PhD part, because what the privileges that they're requesting, we want to do the relevant privileges. So we have to verify that they did their medical school and they did their residency. And so education and training, when I first started doing this, the only way of getting this information was writing to the training program and asking them to verify that they received training, writing to the medical school and asking them to verify that the person did get that training. You can still do that. And in some cases, especially for training, it is a good idea to write to the training program director. If someone's recently come out of their training program, of course you want to write to the training program director and get that verification of the training from the training program director. For someone who's been out of their training for many years, it may not be relevant to get that information from a training program director, because what we're really interested in here is current competence and the fact that they completed that training. So in that case, we may go to an AMA profile and have an AMA profile that will provide that information that they've completed that education and training. So just determining how long that they've been out of that training program and whether or not that information is relevant is something that your medical staff needs to look at. Do you think that, does your medical staff feel that we need to always get training from the program, or are they all right with an AMA profile to verify the training if the person's been out of the program for 5 years or more? So that's something that each needs to look at. So Anne, could you talk about the Symplr process for verification and how that works?
Absolutely. So for all of these different primary source verifications that we're going to talk about today, the Cactus Provider Management Platform has a nice designated data entry spot within the system to store that information. So our customers can either go in and manually type that data in, or if they want to import that information from an online provider application or even from CAQH, they can certainly do that as well. It just kind of helps to take some of the time away that you could be spending typing it in manually. And then you can store images in these records as well. So as Kathy was mentioning, if you had got a letter from a program director, an evaluation form, you can scan that PDF in and then attach it to Dr. Jones's education record for his medical school. You've got it in his file, it's going to be there forever. And then that way you can also not rely on the paper side of keeping those large, bulky credentialing files. We have the Provider Image Manager, which is a really nice kind of overarching view of all the images in your system. And most of our customers will use what's called the credentialing instance when they're credentialing a provider for the first time, or if they're going through re-credentialing. It just helps to track everything you're doing in one nice, easy to find location. And it is configurable. So sometimes you might not want to go back and verify that Dr. Jones went to medical school when he is up for re-credentialing. That might be fine for you to not have to do. So the credentialing instances are configurable so that you can turn off those notifications for the future. Anything that you've already verified once before in the past that is not required again, simply let the system know and it will not send you an alert for that. Now we do have within the credentialing instance links, say for example to the AMA or the Student Clearinghouse, and you can actually create any links that you want that are important to you and important to your credentialing process. Within Cactus, you can always generate letters and you can email them or fax them directly out of your system, or of course print them if you need them to go over to a printer. In the future, we will be integrating with the American Medical Association and then also that Student Clearinghouse. So keep an ear out for us for next year for those two items.
All right.
Kathy, talk to us a little bit about your work history and experience.
Okay. So when we're looking at experience and work history, this is one of those areas where people they vary in how they handle things. Some hospitals, medical staffs will say, we want to know everything from the time that they completed their training program until the day they come to our door. Other hospital medical staffs might say, well, it's important that we know what they've been doing for the last 5 years or the last 10 years. We don't feel like anything that happened 10 years ago is really relevant. So with experience and work history, this varies by organization. Some hospitals will verify, like I said, everything. And some hospitals will just say, we're going to go back 5 years, we're going to go back 10 years. The important thing to keep in mind here is that we're trying to document with this work history whether or not there's any kind of adverse actions by hospitals, which we hope would be in the National Practitioner Data Bank. If somebody were to take such an action against a hospital, we would expect that hospital by law, they're mandated to report that. So we can get some information about whether or not there's a disciplinary action from the actual work history, any kind of reports that would have been reported to the data bank. We usually ask them to provide, their experience. Some people, like I said, will say, give us everything that you've done, but they'll only verify 5 or 10 years. Some people, hospitals will only say, just give us 5 years of history, and that's all they ask for. So it just depends on the facility and what the medical staff feels comfortable with. At one time, we would verify, everybody verified everything going all the way back. And the reason that we did that mainly was because we wanted to make sure that there were no adverse actions by other hospitals. Well, the data bank's been in effect now since 1989, so I would hope that those reports would be there if there was an adverse action. Additionally, there were some lawsuits that were filed back in the 90s where where a doctor lied on his application and didn't include information, and the hospital didn't verify those hospital affiliations, and if they had verified them, they would have found that this doctor had, not been truthful on their application. So because of that, kind of a knee-jerk reaction to that lawsuit where the hospital was held liable, people started verifying everything going all the way back as much as they could. Well, I think now that we've got the data bank established and we're, since 1989, things should be published in there. I think that we're more comfortable with going back just 5 or 10 years and making sure that we have current competency for those practitioners who are new to our facility and we don't have a track record for them. So let's talk a little bit, Anne, about how you can do verifications using credentialing software.
Absolutely. So for obtaining any of those primary source verification letters, say from hospitals or clinics, Symplr has a product called affiliation letters. It used to be called iResponse, and this product directly interfaces with your Cactus database, and it essentially has 2 primary features. The first one is, say for example, I need to verify for Dr. Jones that he is on staff and in good standing at ABC Hospital. The last thing I have time to do today is write a letter, send a fax, give somebody a call. I really need to get this right away. So if ABC Hospital has the affiliation letter product, I can log on to a website, quickly type in Dr. Jones' name, and get that affiliation letter back all within a matter of a few seconds. Print it off, and we're good to go. The flip side of that is I'm a credentialing coordinator at ABC Hospital, and I have no time today to take phone calls, respond to faxes, open the mail, and send a response back. So that's the other benefit. I don't have to respond to any of those folks that are asking for verification letters. They can simply go to my website, get the information that they need, and because everything is hitting that Cactus database directly, all information that's going to be populated into these primary source verification letters are all done in real time. So if I had an issue that just popped up this morning with Dr. Jones, and for some reason I didn't want anybody to be able to see that he's not in good standing, or if I had some other concern, I can actually flag Dr. Jones, and then if somebody tries to query upon him, they will get one of those nice, friendly, please contact the Medical Staff Services Department for more information letters, and go from there. I'm really excited. Coming out later this month, we do have some enhancements that are coming down the pike. So with Cactus 4.1, all of our customers that use affiliation letters will be able to create and manage their own letters. So that's really exciting for us. And then keep your eyes open for a new updated user experience, a new interface. We've got new colors to it, some small feature enhancements, but it's still basically the same product that we all know and love. It's just going to be a little bit bigger and better. For anybody that does not have the affiliation letters product, of course, you can still create and generate any of those products, or any of those letters out of Cactus that you need to, and you can automatically email, fax, and print directly from your system there. Now, one thing, I got up this morning and I needed to go to work. So what did I do? I went out to my car, sat in the driver's seat, started my car, and the first thing I look at is my dashboard. I'm nearly out of gas. So one of the things I did not have to do this morning is manually go and check my gas container. I could just look at my dashboard and see my gauge directly right there. Cactus also comes with a dashboard, and it has these widgets that you can create as a user to check and maintain the health of the data that's in your system. So for example here, I have a work history time gap. So Kathy had mentioned, sometimes we want to make sure that we're checking what people are doing, but then when they're not having some work experience, there's kind of that gray area. What exactly was going on? So this widget here on the screen shows you, for example, John Coleman Adams. He had some work experience shown in blue and shown in green, and then the gray sections are anything over 90 days. You can configure however many days you want, but basically what these widgets do is it just brings that information straight to the forefront, so that way you're not having any gaps or anything that you're not certain about.
Wow, that's a great tool. One thing I want to mention too about hospital affiliation letters, when you're using the the interface over the internet where you're going to and verifying somebody's affiliation using that letter, typically when you're getting your verification that way, those letters will say that they were on staff from this date to this date, and that there's no disciplinary actions, and the boilerplate template language that we see in there. But and those letters are fine for making sure that you're filling in the gaps, that somebody was affiliated with the facility and there's no disciplinary action. But it's really important when you're writing to hospitals that we have somebody brand new coming to your facility, and that person is going to be working at your facility. You need to make sure that you get some kind of relevant information from the hospitals where they're currently working or their most recent places. So if you're really wanting the document experience, we're not documenting just that somebody was on staff and that there was no disciplinary action. We really want to get a little bit more information, like were they, what privileges did they have? Did they do a good job? Are there any kind of disciplinary action? So can those letters, Anne, be customized for giving that type of information to people?
I can double check on that. I'm pretty sure that we can pull in what are called user-defined fields, and we have memo fields that you could type in any additional information that you wanted to share. I can certainly double check on that just to make sure 100%.
Okay, great. I just think it's important that for somebody who's newly coming to your facility that you have something more than just that letter saying, yes, they were on staff from this date to this date and there's no disciplinary action. It fills in the gap. It tells us that there's no, that there were no documented problems with that practitioner, but realistically, someone could be in the middle of a fair hearing for, killing 5 patients and can still have a letter that says, yeah, they're in good standing because, truthfully, they still are. So I think it's important for somebody who, somebody who's newly coming to your facility from another hospital that you get something other than just that little due to the volume of request template letter that you, that are typically generated from the credentialing software. Okay, closed and hard to reach facilities. Sometimes there are hospitals that close and we can't reach them anymore. When that happens, we have to find another way of documenting that person was there. If your policies require that you go all the way back to the beginning, then you need to try to document it. If you get something back saying, no forwarding address, this hospital's closed, a couple of things that you can do. You can contact somebody who is another facility that is part of the system and ask them if they know where the records are. You can talk to someone who is maybe another hospital that's in the area that was unaffiliated, but maybe the medical staff office there might know what happened to the records from the other hospital. You can contact the county medical society and see if they have any idea. So if some place is closed, it's a good idea to try to figure out where those records went. Sometimes there's just no getting them. I know in the 1990s and 1980s, late 80s and early 90s, we had all these mergers of hospitals, and it started and it's just continued since then. And sometimes big hospital systems will buy up a competing small facility that's in their town and they'll close it off. And so those records have to go somewhere. So it's a good idea to try to do a little bit of follow-up and find out where they went, and try to get that. And if you can't, you can't. You know, sometimes places just close, their records get put in Iron Mountain or somewhere, and you just don't know, no one knows where they are, and you can't, or they're destroyed. And so you just can't do it. If you can't find it, then you just document, you know, try to contact, you know, place is closed, can't find anybody that knows anything about it, and there's really nothing else that you can do. Sometimes somebody may ask the provider, hospitals may ask the provider, can you give me the name of someone who you worked with there, maybe a chief of staff or a department chair or someone that can verify that you actually did work there that would know you, and you can follow up that way as well. Licensure is typically, back in the old days, what we would do is we would write to the state licensure board, and we would wait for weeks and weeks and weeks to where they finally would send things back to us. I remember I live in Illinois, but I'm across the river from Missouri, so I work with a lot of, and have a lot of colleagues in the St. Louis area, and as part of our state association, we used to have the people from the state licensure board come and talk to us, and there were two girls. Rose was one of them. I can't remember the other one's name, but they managed the whole state licensure board, and they answered all the questions and processed all the applications. Well, nowadays things are a lot easier. We can go to the state licensure board website. We can go to the docboard.org, where the AIM has some of the licensure boards where you can verify more than one at a time. So we have much better ways of doing it now than what we used to back in the old days. DEA as well. There is a validation tool on the DEA's website, and you can see the link there on your screen. In order to use this, you have to be an organization that has a DEA number, and then you will so that you can then go to this DEA website and validate. You put your number in, your DEA number in, you put the person's DEA number in that you're validating, and it will validate it that way. Otherwise, you have to go to NTIS, National Technical Information Services, which is something you have to pay for. They do have a one query at a time that's $9, or if you subscribe to it, it's over $3,000 for a single user. So it just depends on what kind of, how many queries you're going to need, whether or not that makes sense for you to have an annual subscription or to just do it on a case-by-case basis. You can also get a copy of the DEA. That is something that some accreditors recognize, that if you to validate it, you just have a copy of the DEA. Would you like to talk about License Monitor and how this system, this can be automated within a credentialing software?
Of course. So Symplr has, as Kathy mentioned, a product called License Monitor, and this directly interfaces once again with your Cactus database. So what it does is the product will bring back any data and any images for more than 250 sources across all 50 states. That information comes back into your Cactus database, which really eliminates the need to have to go out manually to these websites and query to see when your provider's licensure is coming back up for renewal. So think state licensure, think certifications, DEA certificates, controlled substance registry, things of that nature. So if you do, however, want to manually verify these items through Cactus, you certainly can. In the bottom left-hand corner of the screen is a screenshot for Dr. Adams. He's got a state license for Missouri. And if I wanted to go out and check on the status of this, I could click on the little blue globe icon that's there. It will direct me to the Missouri Board of Healing Arts website, and we'll even pre-populate a few fields for you, like the name and the license number. And then you, in the manual verification process, can go ahead and check it, and then you can save a PDF directly back into your Cactus system. It's just a little more manual. A few more dashboard widgets up in the upper right-hand corner. We have an expired license widget. You can see in my system today I have 0 that are expired. If I had one, I could certainly click on that, and it will show me all the providers whose licenses are expired, and then I can work them one by one. Now, I used to be a medical staff coordinator, and one of the things that would, of course, always keep me up at night were these different verifications. What was I missing? If I took a sick day, you know, how am I going to get these things verified? The other thing that really kept me up is, what about any of those providers that are out there in my database that just don't have a state license? Maybe I ran out of time, maybe I forgot, you know, I just didn't enter in their state license, but I'm still responsible for making sure that that's up to date. So in the bottom right-hand corner of the screen, I have a screenshot here of a widget that shows me all providers without a state license. So once again, just another kind of check and balance to make sure that you're gathering all of the information that you need to stay in compliance.
Well, you have some very influential people on your medical staff. Benjamin Franklin, Betsy Ross, Rosa Parks, like that.
You know, we only bring in the best and brightest.
All right. Okay, so we also have to verify sanctions and disciplinary action. You know, we do that by checking state licensure websites. We go to the OIG exclusions database and make sure that people are not excluded from Medicare and Medicaid. We also go to the System for Award Management, which is sam.gov. That includes people who are excluded from any type of federal contract, including Medicare and Medicaid. Sometimes they may be excluded from something because maybe they worked for Boeing and defrauded the government and they got excluded from being able to have a contract for aerospace, and because of that they can't have any kind of contract with the government. So you also want to check sam.gov and make sure that these are that these are all there. And it used to be that we had we'd have to mail all this stuff off. Now it's just all available. With the exclusions database, you can also download that database. You can sign up for a monthly email that will notify you when the database is available and when they do the updates. For people who have a smaller medical staff, or you know everybody on your medical staff, they also have this monthly updates. When they update the data file, they also list all the people who are newly excluded. So I always like to recommend that you take a look at that, download that file. It's usually a PDF that's maybe 5 or 6 pages, and look through and make sure that there's no names on there of anybody from your facility that is being that has been excluded. So what is the Symplr process for verification?
I am really excited about this. So later this month, we're going to be officially releasing our exclusion screening product. So this is going to be available for our visual Cactus customers, and then also our customers that will be on Cactus 4.1. So this is going to allow you to compare all of the providers that are in your Cactus database with SAM, with OIG, and with 40 of the state Medicaid exclusion lists. So that way you'll be able to see if there's anybody within your system that is excluded from providing any care to those Medicare and Medicaid patients. It also comes standard with some standard reports, which is perfect for auditing. And then even more exciting is what we have coming in the future. So please stay tuned, watch the Symplr website, check your emails if you're on our email distribution list. We're going to be adding some really exciting sources that I just can't wait to get out to you a little bit later this year. So stay tuned.
Wow. That sounds great. And, it's really important that this is monitored, because if you allow someone who is not who has been excluded from Medicare, Medicaid, your facility will not get paid for those services that are being provided. So if you have somebody who admits a patient and that patient is admitted by a provider who is, excluded, you have to take a look at that, because there may be you may not get paid for those services that are ordered by those excluded providers. Okay, the data bank is, of course, something that hospitals have to query. I put this screen together because I think it's really important to see what exactly is reported to the data bank, what kind of information is out there that we can get. These are the disciplinary action and sanctions that were reported for 2016, and which was the most recent data that was available when I did this in July. If you look at this, state licensure boards have taken almost 5,000 disciplinary actions against providers, but look at the number of privileges issues and membership issues from hospitals and other healthcare facilities, only 626. You would think that would be more, that there'd be more than that. So if you look at the total number, 6,428 exclusions total, either exclusions or DEA actions or memberships in professional societies taken away or state licensure issues. Out of that, only about 10%, less than 10% of those resulted in a clinical privileging action. So it makes it, to me, it looks like there's some disparity there between the number of actions that are taken by state licensure boards and DEA and OIG and how that's relating to hospital clinical privileges. But we are required to query the data bank every 2 years. For practitioners, and also we can use that continuous query option, which automatically notifies you when there's a problem. Back when I first started doing this, we had these horrible forms that you had to actually roll in a typewriter and type on. It was a legal size page that you had to fill out to do a query to the data bank. It wasn't even electronic. So things have progressed quite a bit since then. And we've automated that system even more with the Symplr software.
Yeah, so Cactus is fully integrated with the National Practitioner Data Bank, and it is such an easy feature to use, and it's a huge time saver because all of that information that the National Practitioner Data Bank needs is already in your Cactus system. So there's no need for you to go log into the NPDB. There's no need for you to manually rekey everything in. And then, of course, kind of one of my favorite pieces of it is that there's no additional charge from Symplr or from Cactus. So you'll just pay whatever the NPDB requires you to do. So you've got a couple of options when querying the NPDB through Cactus. The first one I'm calling a selective inquiry. So say, for example, you've got one provider that's going through an initial credentialing, or maybe you've got 150 that are going through your re-credentialing process this month. No problem. Grab those providers very quickly from a query, send those providers from Cactus to the National Practitioner Data Bank by clicking a couple of buttons. Those queries will run through the NPDB, and then the NPDB will return to you a report, and that will automatically attach to the provider's record within Cactus. Very seamless. Your other option is to do a continuous query. So same thing, you're going to pull that information out of Cactus. You would go to the NPDB one time, log in and upload that information. And then the NPDB would contact you via email if any of those providers that you've uploaded have any reports now or in the future. So very simple. If you don't know how to use these features and you're interested, please check your help guide or give us a call, give our client services team a call, and we'll be happy to show you how to use it.
Great. One additional comment that I would make too is that if you're signed up for continuous query, you have to make sure when somebody leaves from your facility that you go in to your databank profile and delete those people from your provider list. Because you don't want to be querying, for one thing, you don't want to have to pay for querying for someone who's no longer on your staff, but also the law does only allow you to query for people who are currently on your staff or getting ready or potential employees and so forth. So you're not really allowed to query on someone who doesn't meet those criteria. Right, peer recommendations are just what it sounds like. We write to peers, we ask them to provide information back to us regarding how someone's been doing, and this has really not changed at all in the last 30 years. We're still doing this just the way that we used to. We do change up some of the questions that we ask. We're asking more behavioral issues now, how they get along with people and so forth. And if you're a Joint Commission accredited hospital, there's some specific recommendations that have to be included, like medical clinical knowledge, technical clinical skills, clinical judgment, communication skills, professionalism, and interpersonal skills. Each of these needs to be addressed in your peer recommendation form. Some hospital medical staffs require 2, some require 3. It just depends on what your medical staff feels comfortable with. And some medical staffs will allow you to have partners provide those recommendations. Some will not. Some will say that they have to be a department head or a chair or somebody with supervisory responsibility, or at least one of the persons that provides that peer has to be have that supervisory responsibility. So these things have not, those recommendations and requirements have really not changed much since I started working, other than Joint Commission nailing down what they expect to see on a peer recommendation, and us including more of the behavioral aspects in those peer recommendations. So how can we simplify this using Symplr?
Today, within your Cactus system, you can create and generate those, easy peer reference letters, and then you can fax or email them out directly from your Cactus system. And of course, you probably want to go ahead and attach that privilege request form and any signed consent forms that you got from the provider that's applying. And then when that information comes back from your peer reference, you can certainly scan it into the system, attach it into the applicant's record, and then make it available in our online committee manager tool that we'll talk about here in just a few moments. But one thing that we are extremely in tune with here at Symplr is the need to make this electronic. So that is something that we're gathering requirements for right now. I mean, you're walking through the hospital, you see providers on their phones. We're all connected to our email at any given time. So we're going to help you all to get that electronic experience out there so that you're not having to send out the paper forms and usually having to send them out 2 or 3 times, because it seems like they tend to get lost in the mail. So stay tuned for that as well.
That's great. Those electronic turnaround, I think the turnaround time on those electronic peer recommendations is certainly better than when you're sending a paper and trying to get somebody to answer it and they have a pile of paper on their desk, waiting for signatures that's a foot thick. So I think that electronic experience is a great enhancement. Professional liability coverage, of course, is something that we have to make sure that people have. We have to make sure when we're looking at those face sheets that the amount of coverage meets the requirements and that the dates of coverage are correct, that they are currently covered and they're not going to be expiring in a week or whatever. Also, check for claims made versus occurrence type policy. If it's a claims made policy, that coverage includes any kind of incidents that arise or on or after that policy's date or the retroactive date. For an occurrence policy, that coverage is only for incidents that occur during the coverage period, regardless of when they're reported. So that means that you don't need tail coverage. So if it's claims made, it only covers you while that policy is in effect. If it's per occurrence, it covers anything regardless of when it's reported. So if the occurrence might happen 2 years later, the lawsuit might happen 2 years later when that the patient finally reports that they're injured, because the statute of limitations runs for a while. So if you have a claims made policy and that claim is filed 2 years later, it's not going to cover them. So with an occurrence policy, it will cover them for incidents that happen during the period, anytime during that coverage period, no matter when those claims are reported. Also look for policy limits, make sure that they are, how they're defined, that if they're per occurrence and aggregate. Per occurrence means for each occurrence that happens. Aggregate means that they will only going to pay for this much within this time period. Usually we see, 1 million per occurrence and a 3 million annual aggregate or something like that. Also look to see whether or not there are group sharing limits. You may have a group policy on that you are provided, and you may have a requirement that each provider has 1 in 3 coverage, and you may have a group that has 10 people in it that is sharing the limits, and you have to make sure that that group sharing limits is going to meet that per occurrence and aggregate limit that you've required for your organization. Also, you can write to the insurance company, ask them to add you as a certificate holder. This will need the consent of the insured, to the owner, to be able to do that. That way you get updates automatically. So when the new policy comes out, you automatically get added, sent a copy of it since you're a certificate holder. Also, you may want to consider sending a copy of the privileges requested or the services that are going to be provided, so that you can see if their insurance is going to cover them for all of these things that they're wanting to request, especially if there's any kind of a question. And then also, there may be some additional insured on the face sheet. For example, if you have an advanced practice nurse or a PA that is associated with that physician or that group, you may see additional insured listed on that face sheet for those people. Liability history, we usually write to the insured to get information from them. We ask them to provide a loss run or a listing of claims or so forth. And we can also look at state and county court records and query and see what that, whether or not there have been any civil actions or criminal actions against that person. We can also ask the applicant to provide the information, which typically is part of the application, that they will provide information as well. And many hospitals will have a form, the specific form that needs to be filled out, that with the specific information about each claim. Also, if we do a background check, criminal background checks on providers, you can also ask for liability history to be included in those as well. And then health status, we're looking at, when we're asking someone to document their health status, whether or not they have the ability to perform the things that they want to do. Attestation statement is a way of doing that. We can have them attest that they are physically able to do the things that they want to do. You can ask them to do a physical exam, especially if there's any kind of concerns about whether or not they are physically able to do the things that they want to do. This is something that when I first started working, we were not doing. It is something that evolved over the years, and it was a real bone of contention for many physicians when this first came out. They didn't think that they should be asked this information, that they shouldn't be required to attest that they have the physical ability and the mental ability to do the things that they want to do. But now it's pretty much common on every form you see it, and some forms even go as far as to ask questions about whether or not they're currently using any illegal drugs or mind-altering drugs, and using alcohol, to more than just an occasional drink and so forth. They've really expanded those health questions in those forms. Board certification is another thing that we verify. Used to be we had to write to the board. Now we can do some of them online directly with the specialty board. Some of them are free. Most of them you got to pay for. We can also use the American Board of Medical Specialties display agents. So all the ABMS specialty boards report their information, and so we can get this information directly from them as a secondary source. Certifax Online, the AMA and the AMA and the AOA both have physician profiles that you can use for physicians, and then for the DOs, the AOA. We have the Federation of State Medical Boards verification service that we can use to verify things. We have the credentialing software vendors that also have information that we can verify through, and Symplr has a product as well.
We do. So whether you are trying to, verify the malpractice insurance or maybe that health status, kind of going back a couple slides to what Kathy was talking about, you can create and generate, once again, those letters in Cactus, and then email, fax, or print. The scheduler, that is one of the features within Cactus that automatically generates and populates these letters for you. So say, for example, first day of the month, every month, I like to run a letter to all of my providers whose insurance is about to expire. Put it in the scheduler, let it run for you on the first day of the month, and then that way it can automatically kick out those emails, or it can automatically print to your printer if that's the route that you wanted to go. Couple examples of some widgets. Looks to me like I've got a couple of expired insurance policies here within my system. I should probably go get on that, figure out who they are, and get them updated. And you can create widgets for the health status as well. So if maintaining flu shots is important to you, or maybe an annual TB test, you can create a widget to show you any provider who's passed their screening date. So that way you're staying in compliance, and there's no worries or wonder about who's out there floating around without their shots up to date. With the boards, Cactus does have immediate integration with the ABMS Direct Connect Select. It fully integrates with Cactus, so you get any data and any images back from the ABMS, and it goes directly into your Cactus database. So if that is something that you're interested in taking advantage of, feel free to let us know, and we'll give you the contact information for Dave Corsi over at the ABMS. He'd be the one that you'd call, and he'd get your account all set up for you and ready to go.
All right, great job. All right, so let's switch gears a little bit here and talk about red flags, unexplained gaps.
I wanted to hop in really quick. We do have some of our audience members that are having to hop off. That is completely okay. We're going to continue running this. That way we get the full recording. If you have to hop off to join other meetings, you will still receive the archive of today's webcast that will have the entire recording. That way you can see all of the program material. So I just wanted to hop in and let everyone know that they can, if they have other meetings that they have to get off and get to. We will send the full recording to them prior next week.
All right, great, thank you. All
No
right,
problem.
so red flags, unexplained gaps, licensure disciplinary action, information on the application that's different from the stuff that people actually send back at you. Sometimes training that took longer than usual. If there's somebody who did a family medicine training program and it took them 5 years to get through that, may be an indication that there's a problem. Sometimes if a hospital will not provide information to you, that may also be a red flag. Negative responses from references. If you can't find 3 people to say something good about you, you've probably got a problem. So also if people put inappropriate references, you want people who are not relatives or not, or not partners, or you want somebody who is a medical director or a department director, somebody that has authoritative responsibility, and they don't provide those types, that may also be a problem. Of course, anytime somebody has an involuntary termination of their medical staff appointment and it's not due to, a contractual issue, or, hospital says we're going to go with a completely different radiology group, or we're going to go with telemedicine, we're not going to have in-house radiology, that would not be a red flag, of course. And frequent moves, unless, of course, someone is in the military, they would move around a lot. But keep in mind that these are usually red flags. It's not always a red flag. If somebody, like I said, has an involuntary termination of medical staff appointment, it's due to a contractual issue, it's probably not, it may not be a red flag. If it's somebody who has a information on the application that's different from what you get back from respondents, you may find that somebody puts a different different date of affiliation because maybe they started at the hospital, 2 months before they actually had their privileges, and they got temporary privileges, and they put that date down as the date that they actually started working there. But when you verified it, you actually got the date that they were approved by the board. So you need to follow up with those on an ongoing basis. When they come in, make sure that they are looked at and that, people are able to fill in those gaps, people are able to respond. Don't be afraid to ask the applicant to provide additional information. If you have negative responses from references, don't be afraid to follow up with those people and find out why they made those negative recommendations, and make sure that that when your committee, your credentialing committee, or your first level of review, that they are looking at these red flags and that they are evaluating them and saying, yeah, this looks like a problem, or this is not a problem, and that they are actually taking those things into consideration. So that's a good segue. Let's talk a little bit, Ann, about the Symplr process for committee review.
Absolutely. So, what, we've worked very hard. We've collected all of our primary source verifications. We took a look at all of those red flags that Kathy just mentioned. At that point in time, you may want to take that provider through your committee review process. So maybe it starts with the department chair, maybe you go through credentials, MEC, and board. Whatever your process is, Symplr has a way to help you automate and make this electronic. So it's called our Committee Manager product. We've had some customers that have fully replaced their face-to-face meetings, and then we have other customers that basically use this product just to supplement their face-to-face meetings. It's completely configurable to fit your unique processes, and you can go through in the credentialing office and flag certain files. So for Dr. Adams, he's a green flag. I didn't see any issues as I was credentialing. But for Dr. Hawkins, wow, she had some issues. I'm going to go ahead and mark this as a red flag. That just really helps your reviewers as they're going through and evaluating all of the different applicants that are in their work queue. The reviewers can only see those files that were assigned to them. And they can go in, they can make recommendations, they can chat with other members that are on the committee, and they can actually send you a message if they have a question about what's contained within a provider's application. Any of those final board decisions that are made are imported back in a Cactus on the provider's record so that you'll have that moving forward, for auditing purposes. And as I mentioned, it's completely flexible and very customizable because we know that all of our clients have different needs and different processes. So if that's something that you're interested in taking a peek at, feel free to give us a call and we'd be happy to show it to you.
Yeah, and I have a question about that. When you're having people do those online committee review, can you actually see who's looked at it and what areas that they've reviewed?
Yes, you can see who's looked at it for sure. So it'll tell you what providers have opened up, who they've looked at, and then the provider can actually go in themselves because that could be a lot of work for them. So there's ways for the provider to go in and filter. Maybe I don't have a whole lot of time today, so I just want to look at providers that are in cardiology, for example. I know those guys, I work with them every day. I'm going to go in and go ahead and evaluate them quickly. So they've got some filters in there to make it quick and easy.
Great. I mean, that's one of the things that I see as a problem with hospitals that I work with is that prior to meetings, people get busy, the doctors just don't have time to come in, and it comes time for the meeting date and nobody's looked at the credentials files, or so that this would be a great way of making that a lot easier.
Absolutely, absolutely.
All right, we're going to switch gears again and just talk briefly about clinical privileges. Privileging, credentialing is verifying all of those credentials, and privileging is documenting what they can actually do, evaluating their patient care and treatment, and seeing should they be able to continue doing these things. So this is based upon the privileges that someone is given is actually based upon evaluating their credentials as well as their ongoing performance within the facility. A little bit of history and background. Back in the old days, admitting privileges were only granted, and they were only granted to physicians, but back then fewer treatment options were available, and so people who, they didn't have all the subspecialty programs that they have now. So people, most practitioners who completed a training program could competently perform those treatment options that were available. You may have, if you have some old credentials files, you may look in them and see that privilege forms were, maybe there was one privilege form used for every provider in the hospital, and they were all doctors, of course, and everybody filled out the same form, and it was only one page. So they would just check the things off that page that they wanted to do. Now, back in 1950s, the American College of Surgeons recommended using this laundry list approach. So they were listing all of these possible things that could possibly be done in each specialty. But at that time, there were a lot of physicians hadn't completed residencies. You could do an internship, a one-year internship, and start working in many states. So many physicians hadn't completed a full residency, so their skills varied. So, and then also as technology kept advancing, our hospitals started trying to do these lists of all procedures that could conceivably be performed for every specialty, and it turns out to be kind of a nightmare in some cases, because those privilege forms are constantly changing, and each time one changes, then you have to send somebody a new privilege form to fill out, and it ends up being kind of a paperwork nightmare. But today, privileges are only granted within an area of practice. If you're a general surgeon, you only get privileges to be a general surgeon. If you are a gastroenterologist, you only get privileges to be a gastroenterologist. Those privileges are not a right. The applicant must actually prove that they're qualified, and we do that by getting that documentation of their training, in their experience, and their current competence. There's a number of different type of privileging systems. We can privilege by categories or levels. We can use lists or those laundry lists, those checkoff lists. We can do core privileges, criteria-based core privileges, or any combination of above. But it's important that regardless of what type of privileging system you have, that you do have a criteria-based privileging system, and that even if you have a list, there should be criteria just to be able to request those things on the list. So you have to make sure that you have these things, this criteria documented, so that people know, heck, if I haven't done this training, then I can't request these privileges. So criteria is very important when it comes to privileging. So how does the privileging module work, Ann?
Well, we have two separate modules within Cactus. We have the standard privileging module, which is what our visual Cactus and our Cactus 4.0 customers have grown to know and love. And then we have the new Privilege Plus module that's available in Cactus 4.1. The new Privilege Plus module, it has the concept of corporate privileging. So if you're looking for some way to kind of unify your privileges across your system, corporate privileging would certainly help with that. There's also a ton of flexibility because we understand that our customers have different needs. In addition to that, we have the privileging library. So Kathy, you had mentioned about the criteria. You've got to have criteria with these privileges. One thing that's a little bit daunting is when you're trying to create a privilege request form or update something that's existing, where do you go? Where do you go get all of this great criteria and content? So the Cactus Privileging Library is integrated with Privilege Plus in Cactus. We have more than 250 specialties and more than 9,600 privileges within that content. It's very dynamic, it's continuously being updated. We actually have a research team that exclusively works with the AMA, medical schools, device vendors, and others, just to make sure that that content that's in the library is currently up to date with any new procedures or any new technology that's out there. One of my favorite features is that it links to the CPT and the ICD codes. So that is really where the magic is going to happen, because we can tie in your provider's privileges with all of those CPT and all of the ICD codes, marry it up with your EMR data, and then generate some very useful reports. So you can see if a provider is performing privileges outside of their scope, how many of a certain privilege they've performed. That'll help you to identify any of those low or those no volume practitioners. It has such a wealth of information contained within that. And then moving on to the versioning piece of things, we understand here that it can be quite a challenge to get these privilege request forms to be approved. So that can take anywhere from 3, 6, 9 months sometimes. So what we do is you have the ability to create a draft. It's a nice little working space where you can go in and, kind of make things the way they need to be in your privilege request form. And then once you're good, once you get approval, hit the publish button. And now those are your live privileges that are out there in the wild for your providers to request. And then they fully integrate with all of our other products that touch privileging. Say, for example, your privileges need to be updated in a couple years. No problem. Hit the library again, bring down all the latest and greatest, get them approved, and hit the publish button again, and now you're fully up to date. And then the last little piece of this is the privilege viewer. So we also know that there are nurses on the floor, there are folks throughout your facilities that need to know what privileges does a provider have today. I don't have time to go look in some shared drive somewhere for a PDF that was signed 6 months ago. I need to know right this second what these providers have. So the privilege viewer is an online module that allows the nurses on the floor to go in and see any privileges that a provider currently has, and then any of those limitations or conditions that are associated with that privilege for the provider. So maybe they have to be proctored. You could certainly add that information in, and anybody could have access to that needs it and that you've granted it to.
Makes sense. And, when you're communicating to stakeholders, this is just not something that we do out of courtesy. There are requirements. The interpretive guidelines for the CMS regs for the medical staff 48222 do say that the practitioner and appropriate hospital patient care areas or departments are informed of the privileges granted to the practitioner. There's another section in the surgical services that says that the surgical services, any place where surgery history is scheduled needs to be notified of what privileges people have, and also suspensions to those privileges. So this is not just something that we're doing out of courtesy. It is a requirement in the CMS regs, and it does flow down into all the accreditation standards too. What other types of things can be shared?
Absolutely. So, it's important that you got all that information in your Cactus database, but it's no good if you can't share it. So we have some online portals. I mentioned the Privilege Viewer. We talked a little bit about those affiliation letters earlier in the program. Committee Manager is that online experience for committee review. Provider Lookup allows any third-party resources that you've given the thumbs up to basically access your Cactus database and see a subset of providers. The Provider Profile allows a provider to see their own data that's in your Cactus system, of course with security granted. And then finally, the Pharmacy Lookup allows anybody that needs to see if somebody has a DEA certificate. You can configure it even to show a provider's signature, for example, if you wanted to make that available via security. And then we talked a little bit about the scheduler, how you can create letters and reports and have those automatically kicked out every so often. We added a new feature called distribution list. So sometimes there might be a report in your system. Maybe you run it the day after a board meeting to show everybody that's newly appointed. And you might want to share that report with people that are Cactus users in your system, but you also might want to share those with maybe your CEO, maybe your marketing team, your director of nursing. So you can add those particular folks to your distribution list, and then Cactus will send those people an email with the report attached to it. So they do not have to be Cactus users in order to get that information from you.
Be so nice not to have to manually get those phone calls and got something from the CEO and they want you to do a list of so-and-so right away and get it to them. You got to drop what you're doing and go take care of it. It's so nice to just be able to just do that, automate that whole process and not have to do that. Same thing with Pharmacy Lookup, having the pharmacist calling you and asking for the DEA number, and just being able to do that, having those online portals to be able to do that is just a real time saver for the medical staff office.
Absolutely.
Okay, so now that we've done all this discussion of what's required, what we've done, what we're going to do, let's look a little bit about some barriers to effective and efficient utilization of software. As a consultant, not fully utilizing the software is the biggest problem that I see for facilities when I go in, and part of that is due to there's a number of different things. Some of it is insufficient training. Somebody just doesn't take advantage of all the training options that are out there, or maybe they just don't have time to do it. Sometimes the facility will not want to pay the money to send someone to an in-person training program or a user conference, but there are always going to be online help available. There's always a help desk that you can call to find things out, but you can't account for not having enough time to do this, because usually as a medical services professional, we don't have enough time in the day to do the things that we need to do to just keep our head above water. And so we say, gosh, I just don't have the time to learn how to set up my software to automatically query all the licenses, or to do the data bank, send the information to the data bank, or to set up these distribution lists or whatever. But you've got to keep in mind that although you may have to take a time to initially set it up, you're going to make up that time in many times over when you don't have to do these things on an ongoing basis. Also, not utilizing all the features of software. The main thing that I see people not using is the privileges module. And the reason that they don't use it is because they say, I just don't have time to set this up. If you take the time to set it up, then it's going to save you so much more time down the road. And also, there are many customizable features that are available with credentialing software, and people just don't take the time to understand what those are or to set those customizable features up as well. Ann, can you think of any other issues where you see people not fully utilizing the software?
Kathy, I think you really hit them. I think you really hit the top four. And if there is anything that we can do here at Symplr to help you all out, please give us a phone call. We've got some phone call or email for that matter. We've got some very, very sharp individuals on our client services team. And you know, you might not have a lot of time to learn something, but if you can send us an email and say, hey, I don't know how to use your NPDB module. Do you have 10 minutes to show me or 5 minutes? We can get connected and certainly show you that. And then as far as, you know, the failure to customize the features, the Cactus web-based product has a full list of user-based preferencing. So we've really designed the system to be kind of for the user, and you can have certain items pull in or not pull in for you to really customize that experience for you. It's something that might take 5 minutes to learn how it works, but man, the amount of time that it would save you is really key.
Right, even something as simple as customizing your screen so that they come up in the same, you know, when you're entering a new provider, if you're manually entering the application information, just having it come up in the same sequence of your application. Something like even simple as that can save you time.
Absolutely.
Okay, so now that we've talked about the present and the past, let's think about what actually does the future hold. And you know, this is something that is going to be based a lot on technology, on what you know, what resources you have available within your facility. I think as when I look at overall at credentialing, I think that eventually we're probably going to get to some type of a mandatory database. It's probably run by the government that or a government contractor that everybody's going to go to and have a one-stop credentialing database. I think that we're going to get to that eventually. I don't know if, you know, how far in the future that might be, but it just makes sense that that's going to happen. I also think we're going to see changes in the National Practitioner Data Bank reporting requirements that will occur, because we have the data bank was put, you know, in effect back in, that stuff was written in 1988 and came into effect in 89, and it really addressed just physicians being on staff and dentists. You know, now we have a lot more people on staff than physicians and dentists. We have a lot more employed practitioners now, and it didn't address employed practitioners. Right now we have people who get their employment terminated and they leave, but no report gets put in the data bank because they've not been, there's no disciplinary action taken pursuant to a peer review action of the medical staff. So I think we're going to see a lot more of, you know, when we saw that listing from the data bank that showed how many, you know, that only about 10% it looked like of the, or less than 10% of the number of people who are being reported or actually, you know, having a disciplinary action taken from the hospital. So I think that we're going to see, you know, some changes as far as that's concerned. And what about technology? What do you see as far as technology?
So from the Symplr side of things, I think there's really two things. And the first one is automation. So we fully understand that there's a demand for all of us to do more with less resources. So we are hyper focused on bringing kind of more automation so that you can achieve what you need to achieve faster than you can today. And the second part of kind of what's there for the future, I think, is just change. You know, we all understand that our future is always changing. So just what we get comfortable with today, it seems like it just changes tomorrow. So it's so tough. It's so tough. So, you know, when you all are out there, if you hear of a new regulation and you think, oh man, that's going to affect me, give us a call. Let us know about it. Make sure that it's on our radar. If you have some kind of an enhancement or some groundbreaking idea, call us about that as well. We just really want to make sure that our products are meeting your needs so that we can really keep you in compliance and ultimately make your life a lot simpler. So please keep us in the loop.
Great. All right. Well, now let's have a quick word from Symplr.
Thank you so much, ma'am. And this, you can advance to the next slide. This is something that Ann has definitely gone over a whole lot throughout the presentation, so I'm not going to spend
a whole lot of time on it. Just you can check out our provider credentialing module from the Cactus Provider Management Platform, along with everything else that comes from privileging to PPR to anything quality related. We have everything to help you out with the full life cycle of your providers. We can now move on to the next slide. This is a questions and comments slide. I did have a couple of questions roll in that I was able to answer. And there was one about widgets. Do widgets work on Cactus and the old Symplr platform, or do they just work on the Cactus platform?
The widgets are only within the Cactus platform, so they would be within your web-based Cactus, which is Cactus 4.0 or 4.1, anything greater than that. They will not tie in with the older visual Cactus system that's out there.
All right, fabulous. Since we have run a little longer than normal, I am going to, everyone else, we will get to your questions offline. I will farm them out to both Ms. Kathy and Ann as well to help get those questions answered for y'all. If you can hit the next slide, Ms. Kathy. I wanted to let y'all know that we do have a telemedicine webinar happening on October 12th. It is with Jan Laws. We are still nailing down all the details, but that will be coming at you on October 12th. Please keep an eye out for the invite and on the website for the invite page as well. Ms. Ann and Ms. Kathy, is there anything y'all like to say in our audience in closing?
No, just thank you all for hanging with us. I know we ended up keeping a lot of people even though we went over, and I appreciate your hanging in there with us.
Yes, thank you so much.
Yes, thank everyone, and I hope y'all have the great rest of the day. Bye-bye.